Welcome to the class. So today's session is on intrapartum care. It is a NICE guideline published in September 2023 and it is updated in June 2025. We begin with our code, Master MRCOG with concept-oriented clarity. Okay, so what does this guideline tells about this intrapartum care? So what the antenatal education about the labor we need to provide. So provide the mother the information about latent phase of the labor, coping with pain, contacting midwife team and emergency actions, and then something what we need to teach the recognition of the labor. So this also we need to discuss with the patient. What is the difference between the brachial contractions and the active contractions? Contraction frequency and the duration we have to tell her. Then water breaking and normal vaginal loss. Discuss and record women's preferences for labor and birth. Okay, so early discussions help in decision making. Women can change their decision anytime, and plans may need revision if complications arise. Because that is why, right from the late antenatal visit, these discussions are happening periodically. Again, when the patient comes in early labor, we have to discuss the same thing. Okay, whatever has her wish in the antenatal period, whether she wants to go ahead with the same, or depending upon the situation, is if at all any change in the situation, maternal parameters or intrapartum antenatal high risk factors, we have to further make any changes. Okay, so this is what is the antenatal education about the labor we need to give. Then what is the service organization? This particular topic is very important from the SBA point of view. Okay, so basically in UK there are 4 birth settings which are available. One is a home birth, second is a freestanding midwifery unit, second is a alongside midwifery unit, and third is a obstetric unit. So all the deliveries are supervised. Okay, here they are supervised by the midwife. Here they are supervised by the midwife and consultant. Okay, so these are under the consultant unit. Okay, also called as CL. And the first option is home birth. Again, here the community midwife will take care. Here, this is the unit which is a freestanding midwifery unit. That means the unit is completely managed by the midwife only. Okay, and this is a freestanding unit. It does not have an obstetric unit associated. While alongside midwifery unit is that it has got an obstetric unit attached to it. It means it may be in the same building. There will be one obstetric unit and one midwifery unit. So whenever there is a transfer, this transfer is very easy. Okay, here will be ambulance transfer. Here there will be ambulance transfer. So these are the 4 different types of birth settings which are available in the UK. So what we need to see, guaranteed timely access to the obstetric unit if the transfer is required. So maybe medical reason or analgesia request. If the patient requires transfer, we need to have a transfer facility, and audit and publish transfer times and reasons for the delay. So we need to have our own statistics. What is the transfer time from our place? Okay, and what are the reasons for the delays, etc., etc. Maintain robust transfer protocols and clear care pathways, especially when crossing provider boundaries. Units are full or closed. Okay. Establish multidisciplinary governance across all birth settings involving midwifery, obstetrics, anesthesias, and neonatology, and supported user representation. Okay, so there has to be coordination among all these. Okay. Now, very frequently asked questions are on these 2-3 slides which we are going to discuss. For all low risk women, okay, so the mother is low risk, there is no antenatal high risk factors, birth is generally safe for both mother and the baby. Women may choose any birth setting, that is home, freestanding midwifery unit, or alongside midwifery unit, that is FMU or AMU, or obstetric units. Okay, so she can choose either of these particular 4 units. Okay, low risk women. But among the low risk women, there are further classification for multiparous and for the nulliparous. Okay, so for multiparous low risk women, safer outcomes and fewer interventions at home and midwifery unit, no difference in the neonatal outcome compared to obstetric units. So for multiparous low risk women, these midwifery unit or the home setting are giving the same outcome as obstetric unit. Okay, no difference in the neonatal outcome compared with the obstetric unit. Okay, is it clear to you? So
Yes, sir.
multipalus, low risk women, the neonatal outcome in these three settings will be same as obstetric unit. Okay, now coming to the nulliparous low risk women, uh, they will ask you SBA and the correct sentence about this one or this one. Okay, what is the correct sentence? Nulliparous low risk women, then FMU or AMU, that is midwifery units. There are fewer interventions and same neonatal outcome as obstetric units, while home birth has got a small increased risk of adverse outcome of the baby. So when we talk about nulliparous low risk women, the neonatal outcome in the birth setting, there is a small increase adverse outcome. However, in midwifery unit, there are fewer intervention and same neonatal outcome as obstetric units. So here, neonatal outcome in all three settings was equal to obstetrical unit outcome. While here, home birth outcome adverse. While these two outcomes same as home birth. Clear this? Okay. You will remember now. No confusion.
Yes, sir.
Okay.
Yes, sir.
Discuss with women include local statistics, midwife availability and likelihood of one-to-one care, availability of birthing pools and pain relief, such as internox, opioids, patient control analgesia, regional analgesia, that we need to discuss. Then we need to talk about the BMI impact. Higher the BMI, that is especially more than 35, it increases the risk of complications, unplanned cesarean sections, postpartum hemorrhage, risk of transfer to obstetric units, stillbirth, neonatal death, NICU admission, and risk higher for nulliparous women with increased BMI versus multiparous women, and advanced care faster in obstetric or alongside midwifery unit than home or FMU. Okay, so these advanced care is more faster if the patient is in obstetric unit or alongside midwifery unit, okay, than in home or FMU. Okay, because the transfer will be required. Here the transfer is very easy because it is alongside the obstetric unit. Okay, now let's see about this particular. So what they have studied this particular, here again on this the questions are asked. What is the most common reason for transfer? So, okay, so they have got a study in which the patients are delivered at home. The patients are delivered in FMU, that is freestanding midwifery unit, or AMU, that is alongside midwifery unit, and these are the number of patients. They ask you what is the most common reason for transfer to obstetric unit. Okay, so the most common reason in all this is a delay in the first and second stage of labor, whether it is a home birth, FMU or AMU. Commonest reason to refer to obstetric unit is a delay in the first and second stage of the labor, which is around 32 to 35% or 32 to 37% of cases. Otherwise, rest of the transfer indications are less. Okay. So the first indication for transfer, this is the only question generally they ask you. What is the reason for transfer to obstetric unit from FMU or AMU or home? It is delay in the first and second stage of labor. On this table, you need to remember this one particular question. Do not confuse about meconium or analgesia request, etc., etc. They are constituting a very small number. Okay. Now, what we discuss about the low risk multiparous woman. In the low risk multiparous woman, what we have discussed, the neonatal outcome is same as home, FMU and AMU. Okay, so look at this neonatal outcome. This is the neonatal outcome and this is the birth outcome. Okay, so this is the birth outcome, this is the neonatal outcome. So if you see the neonatal outcome of around 1000, near about 1000 patients they have taken into account. Okay, and the babies with serious medical problem in home is 3, FMU is 3, AMU is 3, 2, and obstetric unit is 3. So same neonatal outcome you get in all settings. Okay, so neonatal outcome for a low risk multiparous woman is same. Now here, if you see, intervention rate in obstetric unit is high, like forceps, unplanned cesarean section, transfer to obstetric regional analgesia. So all these indications, all these interventions, see the episiotomy rate here and here. Okay, so they are less. Okay, No doubt, this home birth does not mean unplanned cesarean. They are transferred to the obstetric units and then they are carried out. Okay, because regional analgesia facility, forceps, etc., they are not there at home. Okay, so this is after the transfer. Okay, but if you see the spontaneous vaginal birth is highest in the home. Okay, same as here. Here also comparable, but here it is comparatively less. Okay, but the intervention rate is high. Okay. So outcome for babies are similar across all birth settings. Serious medical problems in low-risk multiparous women. Most common is a neonatal encephalopathy and meconium aspiration syndrome, approximately 75%. Okay, so the commonest neonatal problem will be neonatal encephalopathy and meconium aspiration syndrome. 13% stillbirth after the start of the labor care and neonatal death in the first week. So 13% of cases there can be stillbirth or neonatal death among all adverse outcome they are talking about, not among all deliveries. They are talking about among all adverse outcome, 75% cases are neonatal encephalopathy and meconium aspiration syndrome, while 13% will be stillbirth and neonatal death, and less than 4% will be fractured humerus, clavicle, etc., etc. And home and FMU, highest rates of spontaneous vaginal birth. This also we have seen in the chart. Okay, home and FMU, highest rate of spontaneous vaginal birth. Obstetric unit has got a highest rates of intervention for forceps, ventus, unplanned cesarean section, episiotomy, and the baby outcome, no significant differences across the setting. So low risk multiparous women, every information I have discussed from the table, I hope the information is very clear to you. If anything is asked, any sentence, this is true, that is true, select the right statement, you should be able to select. Is it clear to all of you?
Yes, sir.
Yeah. Now we'll go for a low risk nulliparous women and we'll look for the maternal outcome. So approximately 1000 ladies they have studied, and see the spontaneous vaginal birth 794, FMU has got high, then here AMU in 688, lowest in obstetric unit. Again, if you see the ventus unplanned cesarean section, the rate is high. Regional analgesia rate is also high in the obstetric unit. Okay, and see the baby outcome. Okay, these are nulliparous, low risk nulliparous. See the serious baby outcome. Here it is 9, here it is 5. Okay, so it means almost double adverse outcomes for the baby. Okay, that also we have discussed in the beginning. So intrapartum care, medical conditions. So the adverse outcome is for the baby is little higher at home birth, that we need to discuss. Now coming to the intrapartum care, medical conditions and planned place of birth. Okay, so what is important is which place is suitable. Up till now they have not asked, but sometimes they can ask you which place is suitable for this particular patient, whether it is home birth or whether the patient is willing for wants to choose home birth, whether it is suitable or not. Okay, so let's see about intrapartum care and medical conditions and planned place of birth. Certain medical conditions, this increased risk for the mother and baby during or after the labor. In such cases, planned birth in obstetric unit is recommended. Okay, so this should be decided in the antenatal period itself. Okay, and sometimes you come to know some factor in the intrapartum period. Again, you have to take a call on it. Some other factors not listed here may not mandate obstetric unit birth, but require careful consideration. Okay, discuss risk and advantages of obstetric unit with women for informed choice. So medical conditions indicating increased risk and suggest planned birth in obstetric unit. So what are the medical conditions which will indicate the obstetric outcome? So various cardiovascular, respiratory, hematological, endocrine, infective, and immunological conditions such as confirmed cardiac disease or hypertensive disorders or respiratory conditions like asthma, cystic fibrosis, or hematological conditions like hemoglobinopathy, sickle cell, beta thalassemia major, thromboembolic history, ITP, von Willebrand's disease. These patients will deliver in the obstetric unit directly. Endocrine conditions like hyperthyroidism, diabetes requiring medication, infective conditions like hepatitis B, C, toxoplasmosis, active chickenpox, rubella, tuberculosis under treatment. Okay, toxoplasmosis on treatment. Okay, immunological conditions like SLE, scleroderma, other conditions like renal conditions, abnormal renal function, renal disease, which require specialist care: neurological, epilepsy, myasthenia gravis, previous stroke, gastrointestinal like liver disease with abnormal LFTs, psychiatric condition, disorder requiring current inpatient care will deliver in the obstetric unit. Okay. Now, other factors indicating increased risk and suggest planned birth in the obstetric unit. So, up till now, what we have seen were the medical conditions. Now, we will see about other complications, mostly obstetric complications, either in the previous pregnancy or in the current pregnancy. So if it is a previous complication such as unexplained stillbirth, neonatal death, or previous baby with neonatal encephalopathy, preeclampsia, which required preterm delivery, abruption with adverse outcome, eclampsia, uterine rupture, etc. In the previous delivery, you have to go for obstetric unit delivery. Okay, and in current pregnancy, if it is a multiple pregnancy or placenta previa, preeclampsia, PIH, PPROM, anemia, HB less than 8.5, okay, then other confirmed intrauterine death or substance misuse, alcohol dependency, okay, gestational diabetes requiring medication, malpresentation. So these are the factors in the current pregnancy. They will also require obstetric unit for the delivery. And previous gynecological surgery such as myomectomy or hysterectomy, then these patients are to be referred to the obstetric unit for registration and for delivery. Okay. Now, medical conditions which require individual assessment. Up till now, we have seen medical conditions which suggest the obstetric unit, but here it requires the individual assessment for the place of the birth. And which are those conditions which require individual assessment for the place of the birth? Like a cardiovascular condition, cardiac disease without intrapartum complications, hematological or typical antibodies, then sickle cell trait, thalassemia trait. What we have seen previously was a sickle cell anemia, and see here, sickle cell and thalassemia major. Okay, these are the hemoglobinopathies that suggest obstetric unit. But if it is a trait, then individual assessment is required. Okay, so thalassemia trait, sickle cell trait require individual assessment for the place of the birth. Okay, then endocrine unstable hypothyroidism needs treatment change. Infective group B streptococcus, okay, requires IV antibiotics in labor. Then hepatitis B, C with normal LFTs, they also require individual assessment regarding the place of birth. Okay, and other skeletal neurological conditions, gastrointestinal conditions, etc., etc., will require a individual assessment for the place of the birth. Then other conditions which require other factors to consider when planning place of birth, like previous complications like previous stillbirth, neonatal death, preeclampsia at term, placental abruption with good outcome. So here it is a preeclampsia at term or placental abruption with good outcome. There it was a preeclampsia, early preeclampsia
requiring preterm birth.
Yeah, preeclampsia, PH requiring the preterm birth. Okay, so these were the minor things, but you should remember these things. Okay, then previous baby more than 4.5, extensive vaginal or cervical or third or fourth degree perineal trauma, retained placenta, previous term baby with jaundice needing exchange transfusion, major gynecological surgery, they require. These are the other factors when you plan you have to take into account. Okay, and other factors to consider when planning place of the birth, such as antepartum bleeding, it requires assessment. BMI at booking, consider impact on the place of birth, because they require this. We have seen obesity in the guideline. They logistics requirement, equipments are separate, so we have to take all these things into take into account and then decide the place of the birth. Then high blood pressure, hypertensive risk, suspected macrosomia, clinical or ultrasonographic evidence should be there. Induction of labor, higher intervention likelihood is there. Grand multipara, again increased risk. So these are the specific factors we need to take into account depending upon the high risk. Okay. Then care in all birth settings. Follow NICE guidelines on patient experience and shared decision making. Support women's choices when discussing interventions. Encourage questions. Give time for decision making. Provide supported decision making, and always obtain consent before interventions. Actually, these are the important points from part 3 because they check your communication. Okay, so this is important from part 3 point of view. There are no SBA or EMQ on this. Okay, Position mobilization, encourage women to move and adopt comfortable position. Avoid lying flat. Support, women should have support from both companions or of her choice. Then hygiene measures, tap water sufficient for cleaning before vaginal examination. Standard hygiene, hand washing, single-use gloves appropriate. Then PPE use based on risk of exposure, follow infection control protocols. And infection control, PPE use based on risk of exposure, blood, fluids, broken skin, mucosa, etc. And follow national infection control prevention control manual. Okay. Now transfer of care or to the place of birth. Transfer, shift between the midwifery and obstetric-led care may or may not involve moving location, because alongside midwifery unit they are just next to each other. Okay, but if it is a standalone or if it is a home birth, then definitely you will require a change of location. Okay, so base transfer decision on clinical finding, discuss with women and companions, obtain the consent. If transfer is needed, explain reason, process and expected time, address concerns, reduce anxiety, respect wishes. Midwife arranges ambulance if needed and alerts coordinating midwife. There is in the obstetric unit, there will be one midwife who is a coordinating midwife. So that midwife is to be contacted by the community midwife. And this labor ward midwife will then inform to the obstetrician, anesthesia and neonatal teams. Okay, before arrival it's okay. Transfer categories, there are two transfer categories. One is an emergency and another is an urgent transfer. Okay, emergency is a life-threatening situation. There is an ambulance category 1 call. Okay, then there is, you have urgent in which suppose the patient is getting shifted for pain relief and that is ambulance call is a category 2. Okay, then during transfer, keep woman covered and comfortable, allow choice of position as per the ambulance protocol, maintain communication and companionship. Midwife will accompany her, will give the handover to the concerned midwife over there. Monitor woman and fetus appropriately. Birth companion may travel with her if feasible. And if transfer occurs after the birth, ensure that the baby goes with the mother. Okay. Again, there are no SBS up till now asked on this particular topic. Okay. Now coming to the pain relief. Always there will be SB on this pain relief. Okay. What are the attitudes of toward the pain? A professional must be aware of the values and beliefs of the patients. Pain experience is unique, varies with culture, socioeconomic status, and neurodiversity. Then we have non-pharmacological methods and pharmacological methods also. Among the non-pharmacological methods, you have breathing, relaxation, then shower, bath, massage. They are helpful in early labor. Support the choice of aromatherapy, yoga, acupressure, hypnosis if women request, but they are not routinely offered. Remember, these choice, if the patient is asking, you respect their wishes, such as aromatherapy, yoga, acupressure, hypnosis, etc. But we are not offering this. In the sense, from our side, music encourage, then water bath, yes, offer. And monitor maternal as well as water temperature. Okay, it should be less than 37.5 degree. And maintain infection control. There are criteria and those needs to be followed. Then you have sterile water injections. Option for back pain relief. Reliefs will start in 10 minutes. It lasts for up to 3 hours. Initially, there may be stinging sensation and it is given at 4 points, 0.1 ml intracutaneous or 0.5 ml subcutaneously it is given. Okay. Do not offer or advise aromatherapy, yoga or acupressure for pain relief during the latent first stage of labor. If a woman wants to use any of this technique, support her choice. Okay, this we have just discussed. Then advise women who wish to use transcutaneous electrical nerve stimulation. Sometimes there is a SB, I think in books, most probably on TENS. Okay, so what advice should we give to the woman about TENS? That the TENS devices are not provided by the NHS. But if a woman wants to use TENS to manage her comfort during the labor, support her choice. Okay. So, but it is not provided by the NHS. Okay. There is a very little evidence of its effectiveness in established labor, but no evidence of harm. Okay. Other forms of pain relief can be used alongside TENS if needed by the woman. So about the TENS, what we should remember that it is not provided by the NHS. The device is not provided by the NHS. There is a very little evidence of its effectiveness in the established labor, but there is no harm in using. and other forms of pain relief can be used along with the TENS. Okay. For women laboring in the water, here also there is SBA. For women laboring in the water, monitor the temperature of the woman and the water hourly to ensure that woman is comfortable and not becoming pyrexial, and the temperature of the water should not be above 37.5 degree. Okay, so this is the important thing about the water bath. Okay, now coming to the pain relief during the labor. Now during the labor you have inhalational analgesia, pharmacological, mostly opioid agents, and the last one is a ramifentanil, patient control analgesia. Okay, so inhalational analgesia such as Entonox, that is 50:50 oxygen and nitrous oxide, it is available in all settings. Okay, so this device is very easy to use also. So even midwife unit also has got Entonox. It reduces the pain but may cause nausea and lightheadedness. Okay, then among the pharmacological agents, we have pethidine, diamorphine, or other opioids available. It will provide a limited relief with side effects such as maternal drowsiness, nausea, vomiting. There may be neonatal respiratory depression, drowsiness, breastfeeding difficulties. Along with that, always give antiemetic. Okay, along with opioids, you will give antiemetics and avoid water immersion for 2 hours post opioid or if she is drowsy. Sometimes they'll give you the scenario. They will mention that patient wishes to have water birth. Okay, these are the PV findings. What is the best analgesia? So do not select these opioids in that particular case, because you cannot allow the patient to go into the water for 2 hours, even if otherwise she does not have risk factor. But if you are giving the opioid, she cannot go to the water bath for 2 hours. Okay. Is it clear? Is it clear?
Yes. Yes.
Yeah. Then ramifentanil, patient control analgesia. So generally this ramifentanil is given in form of 40 microgram bolus, and there is a 2-minute lockout period. It is a patient control, so patient only presses the button and she'll get a 40 micrograms of ramifentanil. And once this button is pressed, after that automatically there is a lock for 2 minutes. She cannot take more than that. Okay, so that is a lockout for 2 minutes. Okay. It's actually off-label use, used only in obstetric units. Okay, and but along with that, less epidural or then forceps use and increased spontaneous vaginal birth. Risk is that there is a respiratory depression. It requires continuous monitoring, and oxygen and anesthetic support should be available, and needs 1:1 midwife care and continuous pulse oximetry. Okay, so these are the risk. There is a respiratory depression of the mother. Okay, you have to monitor the oxygen, and if the patient has got any respiratory problem, this is a EMQ, I guess, in one of the book. The patient has got some cough and the rals are present, and in that particular case, ramifentanil is contraindicated. Okay. Then coming to the regional analgesia, epidural spinal. Okay. Information for women, only it is available in the obstetric units, more effective than opioids, not linked to the long-term backache or increased cesarean risk, may cause severe postnatal headache, longer second stage, and increase assisted birth. While in ramifentanil, while here there is a compared to the epidural, the less epidural forceps use here with ramifentanil. Okay, and increased spontaneous vaginal birth. While here the assisted delivery is more in the regional analgesia. Okay, second stage is longer, increased assisted vaginal birth, reduces mobility due to IV access and monitoring. Okay, care and observation, you need to have a secured IV cannula. Then you need to monitor blood pressure every 5 minutes. Okay, for every 15 minutes. Okay, blood pressure to be monitored for 5 minutes, every 5 minutes for first 15 minutes, and then to be reviewed every 30 minutes. Okay, then hourly sensory block check is required, motor block if immobile, and encourage upright or moving positions. Mobilization is allowed if safe and checked. Okay, so these are the things which we should know. And establishment and maintenance, use low dose bupivacaine plus fentanyl. Then use patient control analgesia, program intermittent boluses, avoid high concentration anesthetics more than 25%. Okay, so always less than 25% you have to use bupivacaine plus fentanyl. Okay, labor management, delay pushing. Okay, 1 hour delay for multiparous and up to 2 hours in nulliparous. if no urge. Okay, no routine oxytocin in the second stage. Continuous CTG for more than 30 minutes during setup and after large boluses. So the patient should be on the continuous CTG monitoring and continue analgesia until the third stage and perineal repair. Okay. Now coming to the individual situation such as PROM. Now the patient is in patient comes with PROM, that is premature rupture of membrane at term. How to deal with? Okay, initial contact. She may contact the midwifery unit or obstetric units telephonically. Okay, then we need to ask the history, time of rupture, risk factors, meconium, bleeding, abnormal smell, decreased movements, continuous pain, etc., etc., and look for the risk factors. If risk factors, or if we feel that we are not sure about, then ask for the urgent review in person. Okay, and if she is a low risk patient, in person review will be within 12 hours. Okay, but if there is some risk factors, until risk factors or say pyrexia, etc., then she will have urgent review. Okay, so first is a telephonic contact. Look for the risk factors. If no risk factors, she will report within 12 hours, and review can be done at home, FMU, or obstetric units. Then examination. If there is a clear history and on examination you see that the membranes are ruptured, liquor is there, then no speculum examination is to be performed. If you are not sure about the rupture of the membranes, then you will carry out the speculum examination. Avoid digital examination unless she is in labor. Okay, then counsel her that risk of serious neonatal infection is 1% versus 0.5% if intact. Okay, so these figures may be asked in the examination. If membranes are intact, the risk of neonatal infection is 0.5%. Okay, and if the membranes are ruptured, this risk increases or doubles 1%, or and it is more as the time goes. Okay, and 60% of patients, the labor will start within 24 hours. Some need intrapartum antibiotics. Okay, then management option. Expectant management is to be followed for 24 hours. Immediate induction of labor can also be carried out, and discuss the pros and cons and individualize the case. If expected management, that is wait and watch for 24 hours. Offer induction if she is not in labor by 24 hours. No routine vaginal swab or CRP is required. Advise record temperature every 4 hourly while awake, and report color, smell change in the liquor. Bath and shower is safe. Avoid sexual intercourse. Assess fetal heart rate and movements at each contact, and daily report decreased fetal movements. Okay, after 24 hours, if she does not go in labor, then she should be in a birth setting with neonatal services, either obstetric unit or alongside midwifery unit. Stay in the hospital for more than 12 hours post birth, and if GBS is positive, either current or previous with neonatal infection, then offer immediate induction or cesarean if already planned. Okay, so group B streptococci will have a separate guideline. Okay, then coming to the first stage of labor. Up till now, what we have seen, we have discussed about the birth setting. What are the different birth setting? What are the outcomes in the different birth setting? What are the outcomes for low risk nulliparous? What are the outcomes for the low risk multiparous? That all we have seen up till now. Then we have seen the PROM, how the PROM is to be managed. Okay. Then now coming to the first stage of labor. Now, what is the definition of the first stage of the labor? Before first stage, it's a latent first stage, that is the contraction and some cervical change, that is the position, consistency, effacement, and dilatation is there up to 4 centimeters. That is the latent stage. Okay, then established first stage, there are regular contractions but plus progressive dilatation from 4 centimeters onwards. So what we have to do? Early triage and assessment. So the triage can be telephone triage, decide if face-to-face is needed. Face-to-face is early assessment at home or place of birth, and there should be 1:1 midwifery care. Okay, assessment should include woman's well-being, wishes, expectations, concerns, baby's movements, then information about latent labor and pain coping strategies, what to expect from care, and care plan, and when to call back. Okay, support for birth companions should also be discussed, and we need to document everything. So it is mainly the assessment and advices in the latent first stage of the labor. If there are contractions but she is not in an established labor, okay, so painful contractions can occur without cervical change. We will offer support and analgesia, and the patient may stay at home, return unless unsafe, risk of unassisted birth or distress. Okay, so these patients give some analgesia and ask them to stay at home. Okay, and they will return if they have some issue. Okay, initial clinical assessment, like maternal assessment we will do, then fetal assessment we will do, then vaginal examination will be done, and for per vaginal examination there are principles. It will be carried out only if it is necessary. Explain and always obtain consent, maintain dignity. A woman may decline or stop anytime, and look for station, position, caput, moldings, cervical effacement, dilatation, etc., and the membrane status. So this is what we will do. Okay, then after the assessment, in the early or the latent stage of first stage, she may require a transfer. Okay, transfer to the obstetric care. What should be the indication? Maternal indications such as tachycardia, hypertension, abnormal respiratory rate, fever, proteinuria with hypertension, bleeding. This is all we have seen. Or the fetal indications such as non-cephalic lie or high engaged head. If it is a case of HGA or FGR, oligoheteroneous, unheteroneous, abnormal monitoring, decreased movements, called presentation. So these are the fetal indications for the transfer to obstetric units. Then fetal heart rate, auscultate at first and each assessment, continuous monitoring, per fetal monitoring guideline if the risk develops. Okay, continuous monitoring as per the indications only. Okay, other care in the first stage, acidity control. Do not give proton pump inhibitors routinely to low-risk women. Consider proton pump inhibitors if opioids given or season are more likely. So whenever you give opioids, always give proton pump inhibitor along with it. Okay. So eating and drinking, she can drink when she is thirsty and promote isotonic fluids than plain water and avoid excess intakes. Okay. Light diet if desired and unless opioids given or cesarean risk is high. Okay. What is the other care in the first stage? Contractions half hourly, pulse hourly, temperature, blood pressure, respiratory rate 4 hourly, vaginal examination 4 hourly. Remember this, they may ask you very simple questions in the first stage of labor, how frequently the contractions are to be checked. So labor progress in contractions half hourly, pulse 1 hourly, temperature, blood pressure, and respiratory rate 4 hourly. Okay, only pulse is 1 hour, while temperature, these other parameters 4 hourly, PV 4 hourly. Okay, hourly risk assessment for transfer indicators. Okay, then pain management. There is no numerical pain scoring. Then use Partograph once established labor is confirmed. Support emotional and psychological needs. Encourage women to request more analgesia when required. Bladder care, review 4 hourly, urine frequency, sensation, fluid balance if needed, and consider catheter if retention or IV fluids or she is on oxytocin. Okay. Then fluid intake and output, meconium, no questions are there on this. Yeah, here they can ask you about hyponatremia. Okay, so we'll cover this. She can drink when she's thirsty, avoid excess fluids. There is a risk of hyponatremia that may lead to seizures and death. Okay, midwife will check intake and output, fluid balance, monitoring if concerns IV fluids, oxytocin, or certain conditions like preeclampsia or hemorrhage, etc. If 1,500 plus balance is there or symptoms, then obstetric review or sodium test and possible transfer may be required. Do not give fluids just for proteinuria unless she is diabetic. And if it is a confirmed hyponatremia, follow local protocol, alert obstetricians, anesthetists, neonatal team. So always look for hyponatremia, especially if she is receiving oxytocin. There can be dilutional hyponatremia. Okay. For meconium, always document presence or absence. If present, assess for type, discuss transfer, and explain the risk. Okay. So these are the things about the meconium. Now, what is the duration of the first stage? First stage of the labor for primary, generally it is 8 hours and rarely more than 18 hours. For multiparas, generally it is for 5 hours, rarely more than 12 hours. No intervention if progress is normal and the mother and baby are well. She can return to standard care if complications resolve. Okay. Interventions in the first stage: do not routinely perform amniotomy or use amniotomy plus oxytocin. It is not indicated. Okay. Now here there are questions from here onwards. Please concentrate. Assess the progress. it will depend upon her parity, dilation, contractions, fetal station, position, etc. Now, in the first stage, the most important concept here to learn is a suspect delay. Okay, delay suspected if less than 2 centimeter progress in 4 hours. Okay, or slowing of the progress less than 2 centimeter in 4 hours. Okay, management is support, hydration, pain relief, discuss the findings, and carry out vaginal examination in 2 hours. If less than 1 centimeter, then diagnose delay. Okay, so the first concept here is to suspect delay. Okay, per vaginal examination, how frequently we will carry out? We will carry out 4 hours, and the minimum dilatation should be 2 centimeter or more. If it is less than 2 centimeters, so they'll give you the findings. Such and such lady is admitted at 12 o'clock in the midnight. She was reassessed at 4 o'clock in the morning. She was say 4 centimeter, and at 4 o'clock she was 5 centimeter. Then what is the next step? Okay, the question will be, what is the membranes were intact, CTG is good, what is the next step? So the next step should be, what should be the next step? Here we are suspecting the delay. So when you suspect the delay, the next per vaginal examination is to be carried out within 2 hours. And if dilatation is less than 1 centimeter, then you have to diagnose the delay. And once the delay is confirmed, then you have to do the amniotomy. It will shorten the labor by 1 hour, and it will also increase the contraction. Okay, so when per vaginal examination, when the progress of the labor is normal, it is always 4 hours. But when you suspect the delay, that is less than 2 centimeter dilation in 4 hours, then the next per vaginal examination should be within 2 hours. Okay, and if in the next 2 hours, if there is a less than 1 centimeter dilatation, then you confirm that it is a delay. Okay, delay of the first stage. So don't confirm the delay when you are reassessing after 4 hours. At that time, it is always a suspected delay. First, you suspect the delay, then you repeat PV in 2 hours. If the dilatation is less than 1 centimeter in next 2 hours, then you say that it is a confirmed delay. Then you do amniotomy. It will shorten the labor by 1 hour. Okay, and it will also increase. But if no progress 2 hours post amniotomy, in that particular case, you may have to transfer that lady to the obstetric or get the consultant's opinion in that particular case. Is it clear? Is it clear?
Yes, sir. Yes, sir.
So what is suspect delay and what is diagnosed delay? Can anyone tell me?
So if the progress is less than 2 centimeter in 4 hours, or there is slowing less than 2 centimeter in 4 hours subsequently, it is suspected as delay. Later on,
Yeah.
again, we'll repeat the vaginal examination in 2 hours. If again, if the dilatation is less than 1, diagnose the delay and go ahead with amniotomy. Again,
Yes.
once amniotomy done, if there is no progress in 2 hours, then we'll transfer her to obstetric-led care.
And if she is in the obstetric, then there will be senior sleep. Okay.
Yes.
For oxytocin use. Okay. So obstetrician review before starting discuss risk and benefits with the woman. Explain it will speed the birth, but not the mode and the outcome. Remember, it will speed the birth, but not the mode of the delivery or the outcome. Needs continuous CTG monitoring, and there is a risk of hyperstimulation. Always offer epidural before or after starting if requested. Okay, so generally this oxytocin, before oxytocin you have to use epidural. Okay, when starting, no extra IV fluids unless clinically indicated. Monitor fluid balance, and titration is done every 30 minutes until you get 3 to 4 contractions every 10 minutes. If more than 4 contractions per 10 minutes, reduce or stop the oxytocin. Stop immediately if the CTG is pathological, and restart only after review and the consent. Okay. After regular contractions on oxytocin, vaginal examination is to be done at 4 hours. Okay. So sometimes they'll give you the scenario. So this was the situation, initial situation. Then the oxytocin is started. Then what will you do? So next PV will come after 4 hours. Okay. And remember, sometimes they give you the time that the previous vaginal examination was done at 8 o'clock in the morning. So the option might be PV after 4 hours, or option might be PV at 12 o'clock in the afternoon. Okay, then you will select PV at 12 o'clock in the afternoon. Okay, because it is pertaining to the scenario. PV at 4 hours is a general statement, but if they have given the timing in the scenario, select the option with the timing. Is it clear to you? Because they are checking whether you have got a situational awareness or not. Is it clear?
Okay, sir.
So read this particular scenarios very carefully. Okay, so after 2 hours, less than 2 centimeter progress, review for cesarean. More than 2 centimeter progress, repeat vaginal examination 4 hours. Okay, so here diagnose suspect delay after 4 hours of examination. Next 2 hours, diagnose delay. Then you do the amniotomy. Okay. If no progress 2 hours post amniotomy, consider transfer to obstetric-led care or review for oxytocin. Okay. Once this oxytocin is started, then next PV will be after 4 hours. Okay. Then in those 4 hours, if there is less than 2 centimeter progress, then she will be reviewed for cesarean. Otherwise, if good progress, she will be monitored. Is it clear? So there may be a very long scenario from admission to this has happened, this has happened, this has happened. So look into the sequence, what is given to you. Okay. Then coming to the second stage of labor. So second stage of the labor has got two, passive second stage and the active second stage. Passive second stage is a full dilatation before or without pushing. So before pushing, but there is a full dilatation. That is the passive second stage up to 2 hours with epidural if pushing is delayed. Then active second stage when baby is visible or woman starts pushing. Assessment and monitoring. Continue maternal and fetal observation with increased frequency of fetal monitoring. Vaginal examination hourly in active second stage. Assess head position, descent, caput molding, etc. Monitor contractions. Okay. Auscultate 1 minute after the contractions every 5 minutes. This we have seen. Then position pushing with epidural. Avoid lying flat. Side lying may increase vaginal birth chances. Okay. Without epidural, encourage upright or mobile positions, fewer interventions, and better experience. Okay. So the positions will in the second stage will depend upon the whether she is having the epidural or without epidural. Okay. With epidural, she should be side lying. Okay. Avoid flat. Without epidural, encourage upright or mobile position. Okay. So spontaneous pushing is preferred, directed pushing if needed. Nulliparous with epidural, delayed pushing up to 2 hours may help. Multiparous with epidural, delay pushing by 1 hour may reduce the forceps and ventouse use. Okay. So generally, when they have got epidural, you have to delay the pushing. Then supporting the birth. Offer strategies if pushing is ineffective, position change, bladder emptying, support, etc. Respect choices for perineal protection, such as warm compresses, is recommended. Again, this is the SBA. Okay, to reduce the perineal tears, what is recommended is a warm compresses. Perineal massage if preferred. Okay, no routine episiotomy or lignocaine spray. Episiotomy only if clinically indicated, such as forceps, ventouse, fetal compromise, and always use mediolateral 45 to 60 degree episiotomy. Okay. Then women with prior severe perineal trauma, discuss the risk, options, and mode of birth. And FGM and infibulation, discuss risk and delay, etc. Okay. Then supporting the birth. Offer strategies if pushing is ineffective. Position change. This we have seen just now. Okay, this we have seen. Episiotomy only if clinically indicated. FGM, discuss delay, laceration, defibrillation, etc. Duration and delay. Nulliparous with no epidural, birth is expected to occur within 3 hours. Okay, for a second stage. For nulliparous without epidural, birth is expected to occur within 3 hours. Okay, so reassess at 1 hour. If no progress, do the vaginal examination plus amniotomy. Okay, here in the second stage, you have to do the amniotomy after 1 hour. Okay, if no progress after 2 hours, then you have to take the senior review. So nulliparous woman, wait for total 3 hours without epidural. Okay, 1 hour reassessment. If no progress, you will do the vaginal examination plus amniotomy. And if there is no progress after 2 hours, you will get the senior review. Okay, then multiparous and does not have epidural, birth is expected to happen within 2 hours. Okay, so you will reassess at 30 minutes. If no progress, you will do the vaginal examination and amniotomy. And if there is no progress after 1 hour, you will get the senior's review. Okay. So these are the next steps in case of nulliparous without epidural. This is multiparous without epidural. Okay. With epidurals, it is similar but allow extra 1 to 2 hours of passive stage before active pushing. If delay is confirmed, provide support, analgesia, transfer if needed, and senior obstetric review before oxytocin. So oxytocin in second stage, only after obstetric assessment.
Excuse me, sir.
Yes, yes.
Sir, in previous slide, sir, this in nulliparous with no epidural, the 2 hours since the start of second stage of labor, or is it since the vaginal examination it is 2 hours?
It since the vaginal examination, I didn't get you. See, we are going to diagnose second stage on the vaginal examination only.
Yes, sir. Sir, we are doing vaginal examination at 1 hour. Then, if
Yeah.
there is no progress, we'll do amniotomy. Then again, this 2 hours is after vaginal examination or after the onset of second stage of labor. If we treat it as after vaginal examination, the total will be 3 hours by the time senior review is done.
Yeah,
If it
yeah.
is after start of second stage, it will become 2 hours. At the second hour, we are going for senior review.
Yeah. See, I will get back to you this on this particular query again. But what I feel it is after 2 hours of this per vaginal examination, because
Okay.
that complete or because 3 hours we have to wait anytime anyway.
Yes, sir.
You got it. But I'll
Yes,
get
sir.
back to you. I have understood your query, and the query is
Okay.
absolutely right. Whether you have to wait for 2 hours from here or from the full dilatation.
Yes, sir.
Okay.
Yes, sir.
So, but tentatively, I feel that from here we will wait for 2 hours and then we'll get a senior review because we have to expect the birth up to 3 hours. If it is not happening, then definitely there is a senior review. Is it clear?
Okay, sir.
But I'll get back to you on this. Okay.
Yes, sir. Thank you.
Okay. This warm compresses we have seen. Okay. In the second stage, this is the same what we have seen up till now. Oxytocin in the second stage. Sorry. Start with 30-minute increments. Aim for 3 to 4 contractions every 10 minutes and review every 15 to 30 minutes. Expediting birth. Expedite if there are maternal fetal concern. Consider urgency, safety, and mode. Forceps, ventus, cesarean section, analgesia, etc. Communicate decision and record time, etc. Operative birth. Offer forceps or ventus if there are fetal concerns. Prolong second stage or maternal request. If it is declined, discuss alternatives. Okay. Pain relief must be adequate before attempt. The post procedure, give co-amoxiclav IV or alternative if allergic within 6 hours of the cord clamping. If vaginal birth is not possible, advise cesarean section. Okay. Now coming to the third stage of labor. Time from the birth of the baby to the expulsion of the placenta and membranes. Then we have two types of management, active management and the physiological management. Again, here there are n number of questions on this, that is on the third stage of labor. So active management will be uterotonic drug, cord clamping, cutting and control contraction. Okay. The physiological management, there is no uterotonic. Cord clamping is delayed, but it is not advised. Okay, until pulsation stops or the delayed cord clamping is advised until pulsation stops or the placenta delivered, and the placenta is delivered spontaneously or by maternal effort. Okay. Then what are the care principles? Minimize separation of the mother and baby during immediate post-birth bonding. So separation of the mother and baby during immediate post-birth bonding uh, is to be avoided. Means the baby and the mother should be kept together. Record maternal condition, color, breathing, how she feels. Vaginal blood loss is to be noted. If complications such as PPH, retained placenta, collapse, frequent observations, assess for resuscitation, and transfer to obstetric-led care urgently. Woman's choice, discuss antenatal in labor. Option for managing the third stage should also be discussed prior. What kind of she wants, the active management or the physiological management. Okay. And benefits and risk of active and physiological management needs to be discussed. Okay. And there are questions on this most of the time. Okay. about the active management per 1000 women and physiological management per 1000 women. PPH more than 500 ml is seen in 68 cases out of 1000, while it is 188 women. Okay, so risk reduction is by 120. Generally, they ask you the question either how many times it is common. So 3 times more common if it is a physiological management, or they may ask you in these particular figures also. Okay, PPH more than 1 liter is seen in 13 cases. Here it is 29 cases. Okay, that is almost double. Okay, the need for blood transfusion here again 13 and 35. Okay, postpartum anemia more common with physiological management. Okay, need for further uterotonics is less here, while it is quite high. Okay, then side effects such as nausea, vomiting will be very high with the active management. Okay, while it is less with the, this is the only advantage with the physiological management. Okay, generally the blood loss, the blood transfusion, or the post-operative anemia, postpartum anemia, they can ask you. Okay, 30 per 1000 here, it is 60 per 1000. Well, these rates are almost similar, 13, 13 for whenever there is going to be blood loss, there will be transfusion. So these rates will be same, 13, 30. Okay. Then outcomes with no significant difference. Okay. Retained placenta after 1 hour, similar rates, both active management or the physiological management. Antibiotics for bleeding up to 6 weeks, both case require similar. Okay. Satisfaction with third stage management, in both cases it is high. Feeling in control during labor, reported similarly. Okay, so these factors do not have a significant difference. However, these clinical factors have got a very good the important from the active management point of view. Okay, then third stage of the labor, active management benefits reduces the risk of PPH and need for blood transfusion. Physiological management, if requested, discuss the risk and support informed choice. Document the chosen approach in the women's record. Okay. Now, what are the active management benefits? It reduces the risk of postpartum hemorrhage and the need for blood transfusion. This we have seen. The uterotonic of choice for active management. Oxytocin plus argometrin more effective than oxytocin alone in preventing hemorrhage, but higher risk of nausea and vomiting. Okay, so oxytocin and argometrin is more effective, but it has got a high chances for nausea and vomiting. It is contraindicated in hypertension, preeclampsia, eclampsia, serious cardiac, liver, or kidney disease, and always offer antiemetics such as cyclizine if you are using oxytocin and argometrin. Okay. Now, administration. If you are giving oxytocin intramuscularly, 10 units is recommended. If you are giving intravenously, 5 units is recommended. If you are giving argometrin plus oxytocin, then 5 units of oxytocin and 500 micrograms of argometrin. Remember these 5 units of oxytocin, 500 micrograms of argometrin intramuscularly, given immediately after the birth and before cord clamping. So for vaginal, you can give 10 units of oxytocin, you can give 5 units IV, or 5 units plus 500 micrograms of argometrin IM. Okay. Oxytocin is given slowly over a period of 3 to 5 minutes. Okay. Who had oxytocin during the labor and cesarean birth, offer carbetocin IV to prevent PPH. Okay, so these are the recommended oxytocics for the. And what does the NICE advise for the normal vaginal birth is a 10 units of oxytocin intramuscular. Okay. Then third stage of the labor, uterotonic of choice for active management. Oxytocin plus argometrin, this we have seen. Vaginal birth, oxytocin IV, cord clamping and control cord traction. Clamp cord after 1 minute of birth unless it is urgent, that is baby's heart rate is less than 60 beats per minute or the cord issue. Clamp before 5 minutes for control cord traction in active management. Support woman's choice if she wants clamping after 5 minutes. Perform control cord traction only after oxytocin and signs of placental separation, and record the timing of cord clamp. Okay. Now switching the management from physiological to the active. If there is a hemorrhage, placenta is not delivered within 1 hour. Offer switch if woman wants to shorten the third stage. Do not routinely use umbilical oxytocin or prostaglandin. Okay. Prolong third stage. If in case of active management, if the placenta is not delivered within 30 minutes, we say it is prolonged. If with a physiological management, if it is not delivered by 60 minutes, we say that the third stage is prolonged. And follow retained placenta management if the third stage is prolonged. Now, in retained placenta, secure IV access and explain to the woman, do not use umbilical vein agents or IV oxytocics routinely. Give IV oxytocics if excessive bleeding occurs. Assess placenta manually, only with analgesia. Stop if the pain is inadequate. Arrange transfer to the obstetric unit if not already there. Do not explore or remove the placenta manually without anesthesia. So always transfer the patient to operation theater and then only remove or the explore. Okay. Now coming to the PPH. PPH we have discussed separately. We have had a session on the PPH. So risk factors: previous PPH more than 1000 ml, placenta creta spectrum, preeclampsia and anemia, HB less than 8.5, BMI more than 35, grand multipara, uterine over distension, lower lying placenta, fibroid, etc. Labor related risk factors are induction, augmentation, prolonged stages, oxytocin, precipitate labor, etc. And SSRI and SNRI in last month may increase slightly PPH risk, and highest risk in notes. So it should be noted down and in her plan. Okay. Management of PPH. Actually, this all we have seen in a separate guideline. So always initial management will be empty bladder and uterine massage, uterotonic drugs, IV fluids, control contraction, continuously assess blood loss and maternal condition, identify bleeding source, consider supplementary oxygen such as 15 liters per minute and target 94 to 98% saturation, arrange transfer to the obstetric-led care if required, and administer first line uterotonics. Okay, and provide further treatment as required. So for postpartum hemorrhage, what are the uterotonics recommended? So if it is a physiological management, okay, that means there is no uterotonic given, then oxytocin plus ergometrin or carboplast if not contraindicated, or IV oxytocin when access is available. So if there is a PPH, if she has not received the active management or any oxytocin before, then you can give oxytocin plus ergometrin or carboplast, okay, or oxytocin IV when access is available. Okay. Second line will be carboplast. Okay. And how many carboplast you can give? You can repeat every 15 minutes, total 8 doses, or next option is a misoprostol 800 microgram. Okay. Now if she has received oxytocin alone, suppose you have given 10 units of oxytocin, then the next will be ergometrin IM or carboplast if not okay. So you give ergometrin, okay, or oxytocin IV can be given, and second line will be carboplast. Okay, the same carboplast can be repeated after 15 minutes. Then if she has received in the beginning oxytocin plus ergometrin, you give carboplast or oxytocin and repeat carboplast every 15 minutes. If she has received carbitocin, you can give ergometrin as a first line treatment and carboplast as a second line. Okay. Then medicines and PPH. Okay, oxytocin will act in 2.5 minutes and it lasts for 30 to 60 minutes. Ergometrin will act within 7 minutes and it lasts for 3 hours when given intramuscularly. Okay, oxytocin given intramuscularly will act within 2.5 minutes. It will last for 30 to 60 minutes. Ergometrin given intramuscularly will act in 7 minutes and the duration will last for 3 hours. Misoprostol use is off-label. Consult BNF for other drug dosages. Okay. Then tranexamic acid 1 gram IV over a period of 10 minutes may be repeated after 30 minutes if the bleeding continues. Okay. So rest of the things we have seen in the PPH protocol. So I will not repeat this. Newborn care, record Apgar at 1 minute and 5 minutes. Assess color via mucous membrane and nail beds. Record time to regular respirations. Poor condition at birth, follow neonatal resuscitation and take paired cord blood samples after double clamping. Do not routinely take cord blood samples. Encourage immediate skin to skin contact. Keep baby warm with blanket or towel. Maintain airway. Avoid separation in the first hour. Initiate breastfeeding within 1 hour. Okay. Record head circumference, birth weight, etc. Then extra monitoring if mother is on SSRI or SNRI. Okay. The neonatal resuscitation in meconium. Again, there are no questions, so I will skip this particular slide. Then in the third stage regarding the perineal and genital trauma repair, the trauma is to be graded as a first degree, second degree, third degree, fourth degree. This we know, we have seen this. Then systemic assessment, then repair principles. Analgesia is must. Suture muscles for second degree trauma, continuous subcuticular for skin. Use observable synthetic here. Actually, we have separate guidelines. It's better that we'll go through the GTG here. Okay. Here, there are certain definitions which they may ask you as a SBA. Okay, so there can be hyperstimulation, that is overactivity of the uterus, which is defined as tachysystole when you have 5 or more contractions per 10 minutes for over a period of 20 minutes. Okay, so if you have got a 5 contractions over 10 minutes, that is labeled as a tachysystole. Or there may be hypertonicity or hypersystole if your contraction is lasting more than 2 minutes. Okay, that is called as hypersystole or hypertonicity. May or may not cause abnormal FHR patterns such as deceleration, tachycardia, altered variability. Hyponatremia is sodium less than 130 millimole per liter during the labor. Predisposing factor, lower baseline sodium in pregnancy and reduced water excretion in third trimester or oxytocin effect can affect baby due to free water transfer across placenta. Symptoms will be headache, nausea, loss of appetite, lethargy, etc. And advanced features will be agitation, confusion, seizures, depressed reflexes, and coma. Significant meconium, the definition is dark green or black amniotic fluid, thick or tenacious, and any meconium-stained amniotic fluid containing lumps or meconium. So that is called as significant meconium. So these are the couple of things from the intrapartum care. That finishes this particular guideline. Thank you.